We ready to go?
Good afternoon, everyone. It's 4:30, so let's get started. Welcome. For those of you who haven't joined us before, this is Gecko. It's hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. We have these sessions weekly, and today is the last pediatric session for the year. So, welcome, everyone. Just of note, the chat is open for questions, or please feel free to keep them until afterwards and raise your hand and ask questions directly if you prefer. So, with that, I want to welcome Marisa Beretta. She's one of our, can I say, veteran pediatric gastroenterologists now in Johannesburg. She works at the Fitz Donald Gordon Hospital in the transplant unit, where she's really an expert at transplant hepatology. And I'm very excited to listen to her talk today, which is really about a topic that I find very difficult, is who to refer for transplant when, and what assessments we need to do before. So, Marisa, over to you. Thank you so much for agreeing to do this.
Thanks, Tim. Sorry, is that moving? Just wanted to check.
We're not seeing slides yet. Wait, they're coming. Uh, Seeing them, but
Okay.
not in presentation. Now it's in presentation mode and it's moving. Perfect. Thanks.
Okay, perfect. Thanks, Tim. So I decided to give us a little bit of history, context, and then a bit of applicability to the pediatrician who is probably a little bit overwhelmed with transferring a patient or deciding when to transfer a patient over to a pediatric transplant facility because there have been recent communications which have relayed that there is some concern or some inconsistency in knowing who should actually be getting to these facilities for transplant assessment. And then I thought we'd address some of the problems and solutions. And I think some of these are pretty well known, but I think that some of the answers to them are very applicable to us and something that is achievable. And I hope that this is something that we will walk away with feeling optimistic about as opposed to negative. So, oh, except it's not moving. So going down the rabbit hole, I looked at context and looking at the role of the importance of the liver that it played in society. It's been of significance since the Etruscan times, actually. In in ancient times, it actually was used in the art of haruspicy, which was actually the art of divination using organs. And it has got its role in his ancient history. It has got itself immortalized in objects like the bronze liver of Piacenza, which is on the screen. It was used and was referred to as basically the site of the soul, a vital organ, and then it was displaced by the heart. Um, but at the time that it was at its height of importance in ancient society, they had a beautiful interpretation of it. So the referred to as the leg. Porte patus was referred to as the gate. The round ligament, the notch for the round ligament was referred to as the river. And the branches of the biliary tree were actually referred to as exactly what they are named after, the biliary tree. So their interpretation of the liver was much like something that you would expect from a novel, and if you want to take it into direct context, it was probably one of the first novels of Lord of the Rings. So it was such a beautiful concept and it was so well respected out of its society of importance. And I feel like with our in medicine, and the reason why we're now going to forward a few thousand years. The reason why I'm actually giving this talk is because our candidates for transplant are disappearing. So if you look at our list listed, so those are patients who are active on the active list, and currently we have 10. So we are definitely going in the wrong direction. And I issued the 100 challenge, which was a way to try and determine exactly where we were encountering difficulties in getting patients to us. And one of the things that came out of this, it was a form that was inquiring of pediatricians and all physicians actually as to where they were having difficulties, was knowing the candidate and how to get the candidate to a referral center. So, looking at liver disease, there's quite a lot of information in adults. So, it afflicts 29 million adults a year. It's the third leading diagnosis, and it falls within the top 20 causes of death. But what about children? So, we know that there's a prevalence of about 14 per 100,000. It's got a mortality of about zero point 0.2 per 100,000, with a potential life loss of 10,700 years. But it's poorly studied. And the death may be low, but the impact is high. So it affects health, quality of life, number of life years, family interactions, mortality, and the need for transplant. And the reason why it's so difficult to interpret is because although 26% of the population is under 15 years and 9% are under 5 years, within just that age range, the WHO classifies liver disease under multiple areas. So it classifies under non-communicable group 2 digestive disease. It classifies under infectious and parasitic disease. It classifies under other diseases in neonates and in congenital anomalies in those aged 12 to 59 months. So it's all broken up. There's like no cohesion to the exact impact of liver disease. And that's why it's so difficult to interpret the actual impact of liver disease in children. What we do know is that hepatitis afflicts about 21,000 children. Cirrhosis afflicts 27,000, almost 28,000. That gallbladder and biliary disease afflicts almost 3,000, and malignancy affects almost 2,000. And if you break it down, there are multiple pathologies in liver disease, and that's also one of the challenges. So we have cholestatic liver disease, metabolic, mitochondrial hepatopathies, tumors, now what is called metabolic associated steatotic liver disease, autoimmune hepatitis, infections, idiopathic neonatal hepatitis, Wilson's disease, cystic fibrosis. And all of these have individual reported incidences. So if you look at cholestatic disease, it's 1 in 2,500, metabolic 1 in 1,800, mitochondrial hepatopathies 1 in 20,000. And all of these have an incidence, but even then reporting is inconsistent. And suddenly you've got reports of percentages. So for example, hepatitis B affects 2 to 20% of the pediatric population. And these are all inconsistent and very difficult to bring together to give a very good picture of what kind of impact liver disease has in children. Then there's also an inconsistency in age and distribution. So multiple diseases present at different ages. And you can see there's a peak age of presentation between the age of 0 and 2 years. And then it dwindles in the later years, but it doesn't go away completely. And some diseases they are diagnosed primarily in the older years, like autoimmune Wilson, cystic fibrosis, and portal vein thrombosis. So it's a wide variety of diseases. They present over a wide age range, and they're not well documented or well grouped together. And then there's the impact of experience. So over the years, what used to be idiopathic and indeterminate, unknown, through better investigation and an increased number of tests available to us, have resulted in more definitive diagnoses. So the picture of liver disease is also changing as our ability to improve our diagnostic yield also improves. What that comes out to is that in Western countries, liver disease is the 20th cause of death in childhood. It presents most often in the first 2 years of age. It's mainly caused by biliary atresia and genetic cholestatic conditions. And in a large proportion, chronic liver disease in children eventually requires liver transplantation. So the majority of children that you're going to diagnose with chronic liver disease are eventually going to need to be referred to a transplant center. So what about the pediatrician who is seeing these patients? So how do you know to be wary or cognizant of liver disease? So one of the things that often comes up is, I've got a child, they've had one abnormal liver function test. What do I do about it? So this in the study they examined 3,200 children in the accident and emergency department, and they went on to analyze them and see how many of those actually went on to be diagnosed with liver disease. And the answer was quite a significant proportion. So 5% of all children tested eventually landed up with a diagnosis of liver disease. So an isolated aberrant AST and LT is actually of significance to the pediatrician. But what do you do? What action do you take? So once you have discovered that you have a patient with an abnormal AST and ALT, it's not all that complicated in terms of the next step. You just need to extend your diagnosis a bit in terms of doing a conjugated and unconjugated bilirubin, a coagulation profile, hepatitis viruses, and ultrasound, which is mostly within our abilities wherever we practice. So really, it's not all that difficult to take action and potentially pursue a patient with liver disease. But there are challenges. So if you look at our coagulation profile and INR, there are actually two methods. So there's the Quick and the Owen method. One measures factors 2, 7, 10, 5, and fibrinogen, whilst the other only measures factors 2, 7, and 10. Originally, the INR was only designed for those adult patients who are on warfarin treatment for thromboembolism and we know for a fact that coagulation factors are different in children. They mature, so they only reach adulthood levels later on in life. And we also know that cholestasis upregulates factors. So although we use it as an indication of liver disease, it does have its challenges. It's not entirely accurate. The same with albumin. You get gastrointestinal and renal losses. It is low in ongoing inflammation and poor nutrition, and it's got a 3-week half-life, so it's not very representative. Although looking at these challenges, studies still support validity of using these measures as surrogate markers of liver synthetic function. So if we're looking at tests to evaluate the liver, they are mainly AST, ALT, GGT, bilirubin, ALP, and INR. The only problem is they are non-liver specific. They are raised in other organ injuries or with medication. And that chronic liver disease can develop subclinically, even with normal transaminases. And there's no correlation between levels and disease severity. So although we use them, they are not ideal. Raised transaminases common in children in acute illness, so a trend is needed. And the issue is that actually non-invasive tests for the type and severity of chronic liver disease are actually missing. So you need a high index of suspicion. You need to add clinical, biochemical, and radiological findings in order to make a diagnosis. And liver histology actually still remains the gold standard of diagnosis. And the reason these tests are used and what they are used to compile is the PELT score. So the PELT score is our pediatric end-stage liver disease, and the reason why it is of such importance to us is that it dictates 1-year survival if listed, as well as 1-year survival if transplanted. And we use bilirubin, albumin, INR, and the history of growth failure to establish a pattern and a prognostic indicator of where these children are going and when the best time to transplant them might be. So if you're looking at it, you'll see that, for example, if you're looking at a child of 1 year of age with bili of 320 versus the same child with a bilirubin of 200, the 1-year post-transplant survival is much better, even though the 1-year waitlist survival might be similar. If you're looking at a patient with a bilirubin of 90, which is not a lot, it's just bordering on that of the visible spectrum with normal synthetic function, so an albumin of 38 and 1, they still carry a 1-year mortality and they have a good 1-year post-transplant survival. Whereas if you look at the same child, perhaps just a little bit later on in the evolution of disease, where they have a slightly increased bilirubin and their synthetic function is starting to wobble with a bit of an increase in albumin and in their INR, suddenly their 1-year waitlist survival has significantly changed, although their 1-year post-transplant survival remains pretty good. And what that comes down to in interpretation is that this data is actually from our own unit, and you'll see that the majority of our patients, in terms of when they are done, is actually under a PELT of 5. And that's because if you look at PELTs above 15, they have an 85 to 89% 1-year post-transplant survival, but a 65% listed 1-year survival. So you've got to tell your patients and their families that they have almost a 50% chance of mortality if they are not referred for and are not transplanted. Whereas if you look at under 5, they've got a 94% 1-year post-transplant survival and an 87% listed 1-year survival. So the best opportunity for the best results in liver transplant are actually, well, between or up to a PELT of 15, where you're looking at the best 1 year post-transplant survival and you're still not compromising their 1 year listed survival. So it's a balancing. You've got to balance surgical risk against surgical outcome. And the consensus is that when a patient reaches a PELT amount of more than 10, then they should be assessed for transplant. And if they have a PELT or MELT of 17, there is an established benefit to going on to transplant. So that is a very narrow and very low range if you look at a lot of our patients. And essentially, what we are looking at is transplant need, which is dictated as standard of care for end-stage liver disease, for liver-based metabolic defects, for unresectable liver tumors, or for liver disorders leading to suboptimal quality of life. It results in a significantly increased life expectancy in comparison to what is predicted according to the evolution of the disease. And it also results in a substantial improvement in quality of life. What about course specific? So this is where I think we can uncomplicate things because this is where patients have a diagnosis. We know that the majority of them are going to go on to require transplant. And what do I need to look for in these patients to know I need to refer them on for the needs of a transplant? So in biliary atresia, it's persistent cholestasis, progressive portal hypertension, nutritional impairment, and life-threatening or recurrent cholangitis, which is not that difficult to think about. So I posted this on our pause group, which was an 8-month-old with a Kasai done at 5 weeks of age. The stools looked pigmented. The child was no longer jaundiced with a bilirubin of 68. And I asked if this patient should be referred for transplant assessment. And the majority of people said yes, which is actually the correct answer. And the reason being is that 6 months post Kasai portoenterostomy, the surgery is only defined as successful if the bilirubin is 100% normal. And unfortunately, not just in South Africa, but globally, the success of Kasai is limited. So around the world, only 50% of Kasais are successful. And in our context, only 20 to 40% are successful. So we've got a very low success rate. So the majority of these patients are actually all going to be referred to a transplant unit and sooner rather than later. And the reason is that the natural history of patients who do not exhibit bowel flow is poor, whether it's an unrepaired biliary atresia, which only survived 2 to 3 months, or a patient who is only 3 months old but not showing good bowel flow. The answer is to evaluate them for early transplant, ideally by 3 to 6 months of age. So these patients should be getting to facilities very early on and being assessed and actually transplanted by the age of 6 months. And because overall odds show that liver lesions or in recurrent cholangitis, and 80% of all patients who've had a Kasai will be transplanted by 20 years, and the majority of those will actually be transplanted by 4. So these are all patients that should be identified early and absorbed into a transplant facility so that ideal timing of that transplant can take place. And the indications and timing is that, well, we've mentioned that if it's unsuccessful or if it is showing poor drainage, that immediate transfer should be entertained. But the problem is that there are other issues related to our children. So there is a link to mortality under the age of 1. There's links to a massive increase in mortality under the age of 3 months. And the truth is that although we use the PELT score, it's not truly reflective. And in a lot of the places in the rest of the world, biliary atresia patients actually get PELT exception scores, and those PELT exception scores place them at the top of the transplant list in the majority of centers. So although we use it as a marker of intent or need of transplant, the PELT is not very reflective, and essentially any child with biliary atresia who is showing any signs of non-function of their Kasai should be referred as soon as possible to a center and assessed. And at that point, the center will actually be transplanting them shortly. The effect is that if you perform a and we at Donald Gordon perform predominantly living donor liver transplants, at a PELT of anywhere between 15 to 25 with one or fewer systemic complications, you add 17 and a half additional expected life years, which, as you can imagine, is a substantial amount. The challenges are that often we get very delayed referrals. And unfortunately, this results in progressive malnutrition, and nutritional rehabilitation is of utmost importance because there is a exponential increase in risk related to poor nutrition. So if a patient plots below the -2nd standard deviation in either mid-upper arm circumference, weight, or height, their relative risk index is 8 compared to the average patient. So these patients need to be identified early and need to be referred as soon as possible for a comprehensive workup. So essentially, all patients should be followed up at a transplant center. So if you have a patient with biliary atresia, essentially the answer is refer them to a transplant center. The people at the transplant center will always refer those patients back if they are well, if they are stable, if transplant is not imminent, if things are looking good. Those patients will be referred back into their referral centers because those patients will be able to be managed at that level. If we go on to our next course specific, we're looking at cirrhosis. And this can also be simplified in that anyone with portal hypertension and complications or decompensations need to be referred. And these are also easily identifiable. So if we're going to diagnose cirrhosis, it's not as easy because there are a-specific signs like anorexia, but then there are more specific features like signs of portal hypertension, palmarothema, spider angiomata, digital clubbing. The liver size is not an indication. So the liver size can vary. So just because you've got a big liver doesn't necessarily mean you're not cirrhotic, which is one of the misconceptions that people carry with them. Several tools can support the suspicion. So you can get these features on physical examination. You can do an ultrasound, you can do elastography, you can do CT, you can do MRI. But unfortunately, the gold standard is still biopsy. And if we want to go on and diagnose decompensated cirrhosis, this is a failure of liver function. So the liver is involved in synthesis, detoxification, excretion, storage, and filtering. So if you get a loss in any of these areas, then the patient has decompensated. So it presents as a failure, which can manifest as jaundice, pruritus, an upper GI bleed, ascites, confusion, or spontaneous bacterial peritonitis. And if you look at these, you can see that these three are clustered under portal hypertension. So decompensation overlaps with portal hypertension, both of which are indications for transplant. But there are also complications of cirrhosis, and these are quite variable and much more difficult to diagnose. So there's hepatopulmonary syndrome, portopulmonary hypertension, cirrhotic cardiomyopathy, hepatorenal syndrome, and hepatocellular carcinoma. In addition to which, there's also endocrine complications, and I think that these are often underdiagnosed and underappreciated, which is growth restriction. So growth restriction is a complication of cirrhosis, as well as osteoporosis, delayed puberty, and adrenal dysfunction. And the thing about these is that they are difficult to identify, and they are also indications for urgent transplantation. So, for example, hepatopulmonary syndrome carries a PELT classification of 21 because of its significance. It's irreversible. The only solution for hepatopulmonary syndrome is transplant, and it is progressive to an extent where your patient may no longer actually be able to accommodate transplant. So these are complications that are difficult to diagnose but carry just as much significance. And just as with the compensations, complications also overlap with portal hypertension, with hepatopulmonary syndrome and portopulmonary hypertension, as well as hepatorenal syndrome being secondary to portal hypertension. The impact is that survival without transplant in patients with either complications or decompensations is reduced by 20 to 50%. So that's a significant impact on survival. So the untransplanted. What about off? Okay, now this one is one of my easiest. So I presented this one on our group. I said a 2-year-old presents with hepatitis A, AST is 256, ALT 312, normal bilirubin, INR 2.4, given vitamin K doesn't correct, given FFP incorrects, normal neurology, do you need to transfer to a transplant unit? And this, I think, is one of the easier ones to know about because pediatric acute liver failure is actually defined as a coagulopathy without evidence of chronic liver disease, with or without the evidence of hepatic encephalopathy. So your coagulopathy is defined as an INR of greater than 1.5 with encephalopathy, or an INR of greater than 2 with or without encephalopathy. The second's the easy one. So if you've got an INR of greater than 2 that does not correct within 6 hours of administration of vitamin K, we do not go the route of FFP. And the reason we do not administer FFP is because it does not correct coagulopathy, it masks coagulopathy. So it gives you a false sense of security. So if you have a patient with acute onset hepatic dysfunction, INR more than 2, you administer vitamin K, and 6 hours later, that INR remains above 2. That patient meets criteria for pediatric acute liver failure and needs to be transferred to a transplant center. The more difficult one is an INR of more than 1.5 with evidence of hepatic encephalopathy. And the reason this one is challenging is because of trying to identify encephalopathy in children. So if you go according to the NASPGHAN guidelines, early stage 1 and 2 encephalopathy in children under the age of 4 includes inconsolable crying, sleep reversal, and inattention to task. And I think that this is incredibly difficult to differentiate because most sick children will manifest with one of these. So essentially, any child that has an INR above 1.5 that is not correcting, that presents with any change in neurological status, should be considered as a patient with pediatric acute liver failure. In those over 4, it's a little bit more sensitive because of their ability to communicate and convey. But stage 1, which is prodromal, is just as difficult to diagnose with mood swings, euphoria, depression, confusion, slowing of mentation and affect, untidiness, slurred speech, and disordered sleep. Now, again, these are all things that a child who's 6 could present with. So once again, any child that is presenting INR above 1.5, not corrected after vitamin K, and who is presenting with any change in their mental status should be considered as a pediatric acute liver failure. So, as to when to transfer, it's pretty definitive. If any patient meets pediatric acute liver failure criteria, clear answer to contact or transfer to a liver transplant center. And the reason is because they need to be admitted as early in the disease course as possible because it's rapidly progressive and unpredictable. You actually would like to have them transferred before the onset of hepatic encephalopathy has evolved. And actually, centers favor listing during workup and ongoing intensive care treatment within the first 24 to 48 hours. So if you do not transfer those patients, there is a missed opportunity to both access the center and for optimal medical treatment. And if you look at the pediatric acute liver failure study group, the patients actually were all listed within a day after enrollment. So that is how aggressively pediatric acute liver failure progresses. And that is why it's so definitive in terms of when to transfer a patient. Criteria met, patient gets transferred for transplant assessment. And then we get on to the ones that are a little bit more contentious but are growing. So inborn errors of metabolism. So we've now got a growing cohort of patients who are failing medical therapy or we know will have progressive extrahepatic complications. And if you look at our experience at Donald Gordon, we have experienced patients with alpha-1 cystic fibrosis, Wilson's urea cycle, hyperoxaluria, organic acidemias, and PFIC. And our indication is actually growing. And the reason it's growing is because it's growing everywhere. So it accounts for up to 30% of transplants, like in the USA, and over 10% in most places. And the truth is that these patients have a realistic expectation of close to normal life expectancy after transplant. And it results in often a lifelong correction. And it has come to be recognized that further delay in transplant actually puts these patients at a risk of irreversible damage. And the issue as well is that they are difficult to recognize because they experience a honeymoon period, which is under the age of 1 year of age. They have rapid growth. They are using a lot of nitrogen. And because of this, in particularly urea cycle defects, patients look well, and then they reach the age of 1 year, the honeymoon period is over, and they manifest with episodes of significant decompensation with the risk of damage. And it has evolved from treating disorders where the result was end-stage liver disease to correcting metabolic defects with structurally normal livers. And the majority of enzymes involved in metabolic pathways are actually located in the liver. So a lot of the times, liver transplant offers either a cure or, at the very minimum, a control of the manifestation. So we've gone from preventing metabolic crises and arresting progression of neurological dysfunction and preventing damage to end organs whilst addressing end-stage liver disease to a situation where we're able to promote a life where they don't have a restricted metabolic diet, they don't have to use lifelong toxic medications, they don't have to be frequently hospitalized for decompensations, and at the end of this all have an unsatisfactory neurological and intellectual outcome. And malignancy. So there actually isn't much on malignancy because this falls under the surgical domain, but it's an important arena because unresectable HCC or hepatoblastomas are also an urgent indication. So if you are practicing in oncology or you're practicing in the surgical domain, if you have any patient who has unresectable malignancy of the liver but does not have any metastases, those patients all qualify for urgent transplantation. And there is one little one there that I initially forgot about, but it also messed with my aesthetics, which is why I did not go throughout the presentation, but portosystemic shunts. And I think that sometimes we forget about these guys, but portosystemic shunts are often congenital. They are a congenital link between your portal and your systemic circulation. And most of the time, the reason why these patients should be considered for transplant is because they encounter the same complications of portal hypertension that our patients do with the development of hepatopulmonary syndrome and with portopulmonary hypertension. So they're another important cause to consider. So, what does referral afford? So, early referral, that is, because that's what we're trying to advocate for. And I think there are other things. It's not just about the disease. So, early referral allows for a strong working relationship between the caregivers at the transplant center. And so, it allows you to work on your communication and your relationship with that family. And it allows for us to do includes looking at and confirming the indications, making sure that there are no contraindications, and then doing a nice, robust social and psych evaluation. And a lot of people talk about the social and the psych evaluation, and they would like to know, well, who qualifies? And the important thing about the social and psych evaluation is it's not a static evaluation. So a social and psych evaluation begins with their contact with our unit and it continues. And there are patients who, over time, will actually fail to meet criteria, even though their screen might have been encouraging. And then there are patients who will actually meet criteria, even though their screen was not encouraging. And it also allows for early family education. And we are exposing these families to massive amounts of information. And it takes months for these families to absorb this information. So having the opportunity to allow them to engage with us and properly get proper education is vital. And what does it involve? Well, excuse me, it involves our surgical teams, hepatologists, radiologists. I'm not going to go through everyone there, but I just put this there so that people can appreciate that there are a multitude of people that are involved. But most importantly, at the center of this whole assessment is the patient and their family. And we go through a number of assessments. So included in those assessments is nutritional. And we've discussed some of the importance of nutrition on their risk stratification. But just as important, in every domain that we examine, there are absolute contraindications that would preclude them from transplant. There are reversible factors that require time to reverse. And then there are other issues during these assessments that are unexpected and may take up to months to resolve. And if they are within our group, with us at our center, this affords us the time to allow them the opportunity to reverse that issue. And some of these challenges we share. In fact, we share all of these challenges, and they go across multiple domains. And some of these are biological, and some of them are social. And I just wanted to highlight some of these because these are actually shared across all transplant units. So late referral is one of the biggest challenges we get, where transplant is treated as a last resort, which actually results in low transplantation rates and increased morbidity. This is often compounded by patients who are referred late with severe malnutrition and failure to thrive, multi-organ involvement, and they require intensive medical nutritional support. And because they are referred late, they are often not afforded the opportunity to reverse those problems because they need time. And unfortunately, time is something that when they are referred in extremis, they do not have. We have a high infectious disease burden, so we have a higher TB, Hep B, HIV, malaria, and parasitic infection rate. We have risk of transmission from donors to recipients. We have the risk of reactivation in recipients. We are endemic for TB, Hep B, CMV, and EBV, which all confer increased issues in both transplantation and post-transplant management. And our post-transplant infectious complications contribute significantly to morbidity and mortality. And then there are the social domains. So a lot of our patients are, well, our families, at least one person in the family is unemployed or dependent on social grants. Family dependents are quite there. There's quite a few family dependents. There's no amenities. There's no food security. A lot of these people live far away from our center. The level of care available at the nearest center is poor. They don't have access to early diagnosis. They don't have access to referral. The distance even to local clinic, district hospital, or tertiary center carries travel costs. And as everyone knows, we require temporary relocation. And home where they come from, and even after temporary relocation need to go back to, may not have access to 24-hour medical facilities, post-transplant care, not even a clinic or even a dedicated medical caregiver. And these are all things and challenges. And I think some of the issue is that people look at challenges like this and they don't even refer the patient. And the truth is that these are challenges that can be combated. And they're challenges that can be combated from the referral source as well as through our institution. So with the recipient, we can improve through education, awareness, centralizing and specializing our care for the transplant candidate. With infectious diseases, we can mitigate the risk with awareness, risk stratification, protocols. At DG, we have microbiology surveillance and an antibiotic stewardship program. And with social, there's charitable organizations. We don't really have much governmental, but we've got a few NGOs. And through empowerment of local healthcare providers, which is you, and education and awareness, and knowing who to contact at a referral institution and establishing communication routes, we can actually help even alleviate the distance to center, which a lot of people think is an absolute contraindication to transplant. So these are things that we can mitigate from the medical perspective. And I wanted to highlight the fact that this is not a static assessment and that a lot of the time preconceived notions might actually mislead us. So I gave a few scenarios with a family living on a mine in a single room, 7 hours away by bus, with a family who don't speak English, who are dependent on dad's employment at the mine, versus a family living in Zimbabwe who's well resourced. They've gone over to Germany to get a second opinion on the diagnosis, but have expressed concerns about medication and the way forward. Family three actually lived in Durban with both parents employed. Dad was a pharmacist. They lived close to a major hospital and had their own transport. And the last was a child who lived in the Eastern Cape, 18 hours away by bus. Mom was a social worker in an acrimonious marital relationship. Dad is an engineer living in Joburg with his mistress. And the reason I shared these is that they're all real life experiences. So these are all our patients. And if you did a spot screen on these four families, A and D would pass and B and C would in fact, A and D would fail, sorry, and B and C would in fact pass. And this is the importance of getting a thorough evaluation by a social worker and someone who is experienced and having long-term follow-up at a center that provides support because we were able to introduce factors that alleviated and removed a lot of the obstacles in A and D, and those patients actually successfully made it to transplant. Whereas B and C, they had absolute contraindications. So a lot of people ask, well, what can we ask about social context? And it's not so much about a social context at any spot point in time, but more about their social context as we try to serially assess it over time. And these questions are a few that are asked, and this is actually out of a UK paper. But these are the questions that are asked to our families and how we kind of put together their social assessment. So we like to know who will be the primary caregiver. If that primary caregiver is not available, who will be the backup? What our family needs regarding daycare, kindergarten, or school after transplant? Who will be looking after siblings? Is there any family support? Do parents have any resources to cover hidden costs? What about accommodation before and at the time of transplant? Is parent employment going to be at risk? Are they one or even both going to lose their job if there's a prolonged absence? And is insurance cover adequate? And are there any restrictions in the gaps? So these are questions that are put forward, but they are not contraindications because if any deficit is identified in any arena, we then work towards fixing it and reassessing it. And a lot of the times, our patients will come up with, along with our social workers and our support systems, some sort of solution to these problems. And the reason why it is so important is because there have been multiple papers that have been written on both the financial and the social burden on patients and on the impact that they have in that they are adverse recipient outcomes. And there's papers that come out of Canada, the US. So this is not a thing that's singular to South Africa. It's shared. Transplant is an incredibly resource intensive intervention, and families unfortunately bear some of that burden, and it's a burden that we actually cannot reverse because there are hidden costs in any medical intervention. So we can support, but we cannot completely remove the additional cost of accommodation and transport and the tiny, like any kind of influence that it might have on their employment and their long-term income into the family. And for our patients, what is the impact of transplant? Because you might say, well, what with all this financial and the social burden, is transplant really worth it? And the truth is that parents of children who underwent liver transplant were very satisfied with the health care services provided to their children. So they did, however, have more difficulties after transplant. So what essentially translates into is that the quality of life of a child is exponentially improved after transplant, but the quality of life of our parents and our families are actually slightly compromised. So when we go into transplant, we need to make sure that there is a little bit of a buffer available to our families and that they have the capacity to accommodate a slight deterioration in their quality of life. And then parents and other pediatricians and other providers will ask, well, what do you mean by a drop in quality of life? And it is related to the needs of transplant on that family. So you're looking at a family who have to get medication every month because it's life-saving. They have to come and see us at our center for complications for which interventions are only available at our center. They have to be confident and educated in post-transplant complications, and they have to be looking out for them because we rely on their families to be the first kind of port of call for these complications. So that is a stress that cannot be removed. It's not a stress that can be alleviated. It's a stress that we need our families to be taught to deal with. And although the child's health is improved, this is something that has a knock-on effect on our families. So no family will tell you that they don't want to transplant. So we have to help them navigate this, and there are ways, but it needs to be a realistic expectation, and the social demands need to be properly communicated to these families. Saying that, like I mentioned, there is social support available. So some of our families we help get grants. They still qualify for grants. Some of our families get access to charitable organizations. And for example, one of the organizations we access is actually Wings and Wishes. And this is one of our little patients who is M, and they helped bring her up to our institution 18 times before she was listed. So, in the process of trying to navigate her pre-transplant or her pre-candidate route, she had to come to us 18 times. And through that whole journey, Wings and Wishes supported every single trip up to us. And eventually they supported her trip up to us when she was called up. And Emma's now almost a year post-transplant and doing very well. So a lot of these families, if you afford them the opportunity and you access a resource and you put that resource into place for them, you remove the obstacle that dictates whether they qualify for transplant or not. And then there's other avenues. So a lot of our families can access their own their own fundraising capacity. So these are all on BackaBuddy. So I think everyone is familiar with the platform, but these are all families who are seeking fundraising for liver transplantation. Judah's actually post-transplant now. This is historic. It's still up on the platform, but he's post-transplant and doing well. And you can see that a lot of families are accessing these types of fundraising facilities to try and raise money for transplant. However, the truth is that they do need to have a realistic expectation. So in South Africa, if you're a South African citizen, your ongoing medical care is rendered to government and they can access medication through government. But one of the challenges is that if you're a non-South African citizen, you do not qualify for medication once you reach the age of 5. So if you're transplanted under the age of 5 and you are a non-national, as soon as you reach the age of 5, you no longer qualify for medication. So what you would need to make sure of in that situation is that those families and those patients will somehow have something in place to help them get access to medication after the age of 5. So the challenges are that transplant's expensive, it has hidden expenses, it has additional challenges that are presented to the families, that those challenges can be mitigated but not removed, and that any family that goes through transplant needs to have some capacity in order to be able to navigate it successfully. And I found this amusing because I Googled the cost of transplant in South Africa and it came up with $50,000 to $120,000. Um, and I'll be honest, that was cheap. So we're sitting at about a cost, a quote is at present 1.6 million, and a lot of our patients can go well over that during the course of their admission. So it's expensive and it needs a lot of support, but it's not impossible. And I just wanted to give everyone just a brief idea about what happens after the fact. So once you've referred your patient, we've done their assessment, we've done their patient workup, or the recipient in this case, and we then present the patient at panel. And the panel consists of all subspecialists involved and people who are not just limited to within the patient's the patient arena. So in our case, it's the adult hepatologists and anesthetists. And essentially, that panel agrees that transplant is indicated, that there are no contraindications, and that transplant will, in fact, afford a better quality of life for the patient. So it's a very important discussion. But at that point in time, they are, for all intents and purposes, actively listed. And this is essentially what they look like when they're actively listed. So it's their name, their age, which is of import because our pediatric patients get priority and allocation for all donors under the age of 40 years. Blood group, which is documented but not like of absolute significance because we can do incompatible, but we first go blood group to blood group compatible. Height, weight, MUAC to determine whether a whole reduced size or split liver graft is appropriate. one donor liver may not be suitable for one child and completely unviable for another. And we discussed the nutritional status, how it impacts on perioperative risk, and how important it is. So the height, weight, and MUAC actually holds a lot of significance in the active list. The doctor who has referred and might potentially actually be managing the patient, especially if the patient lives very far away, the attending physician is going to be consulted to provide up-to-date clinical status and suitability assessment. So if a call-up happens, the physician who is attending gets the call and gets asked what the status of the child is. The pelt or melt, as we discussed, dictates their mortality risk and also dictates how well they'll do after transplant. Diagnosis, which also carries a significance in terms of their outcome, and then their address and their contact details. So it's very practical, but each piece of information on that active list has importance in terms of access and prognosis. So I suppose I've gone through a lot of things, and I hope some of them have helped to uncomplicate something that might be said to be complicated in and of itself. But I wanted to just highlight that, I mean, the liver has been recognized as vital since antiquity, that there are massive knowledge gaps on liver disease in children, that although we don't know much about its impact, that we can identify that it's significant in both mortality and morbidity, that liver tests are not specific and need to be interpreted as part of a holistic assessment, and that any patient that has suspected chronic liver disease or established liver disease with complications should be referred earlier rather than later, because referral timing is course specific and should be done as soon as possible to give every child the best opportunity. And that also problems candidates have, they present, they may be present, they may be present, I left out a B, may be present, but they also have possible solutions. So just because a candidate doesn't meet criteria at any given point in time doesn't mean that that candidate will never meet criteria. So there are medically reversible contraindications, there are socially reversible contraindications. And it would really be of best interest to families and to patients if every patient who potentially needs a transplant at least gets afforded an opportunity to get contact with a transplant unit so that they can have had every opportunity to access that resource. So coming out of our 100 survey was that 51.2% had a lack of awareness of referral criteria, 40.6% were unclear on referral guidelines, and 61% had uncertainty of the referral pathway. So what they asked for was clear referral guidelines and overwhelmingly a streamlined referral form. So we've actioned that. We've created a pediatric liver and liver transplant services referral form, which is now available. It's a digital link that you can access. And on that form actually is what I've discussed in this presentation today. It helps categorize patients under course-specific indications, and it helps you also categorize your patient as emergency, urgent, or just a standard referral. So if you access this form and you tick off everything, you should actually be able to see, A, if your patient needs referral, because if you're ticking any of the boxes under that form, then your patient needs referral. And secondly, how urgent your referral is. And hopefully, and everyone's welcome to give us feedback, this will help people navigate our candidates a little bit more efficiently. And this is what it looks like. I hope it's not cumbersome. It's got 8 sections to it, and basically it leads through all of the categories we've discussed, and essentially it gives all the information that you need to convey to our transplant unit about candidacy. It also tells you how to get hold of us, so it gives you contact details for both in hours and after hours, and it allows for you, hopefully, to contact us at any given point in time much more efficiently. I'd just like to take this opportunity to thank everyone for joining us this afternoon. I hope I didn't bore everyone. I hope I made it a little bit simpler. And just of note is our biliary atresia mix match day is approaching. So please pull out your orange, yellow, green, cream, or yellow white socks. Take a picture, snap it, and post it in a way that we can try and raise some advocacy and some awareness about biliary atresia. Thank you.
Thank you, Marisa. That was excellent. I can hear your passion, and it's lovely to hear. It was an excellent talk. I'm sure there are going to be many, many burning questions, but we'll start with the ones in the chat. There's one from Elise de Kock, who says, "Is the ammonia level relevant in diagnosing liver failure or identifying who to refer?"
No. So, and this is actually this is why it's not included in the definition, because it's not reliable. So we've had patients who have arrived with a normal ammonia, who have an ammonia that is over the 150 mark within 12 hours of arrival with us. The clinical signs are far more sensitive. Far more sensitive. So if you've got a child who is clinically presenting with any altered mental state, that patient is, for all intents and purposes, encephalopathic. You don't need an ammonia to confirm that. And it's actually a good thing because ammonia is incredibly difficult to test to conduct both ways. So it needs to go on ice. It needs to be done within 2 hours. I mean, I know a lot of people work with the NHLS as their laboratory of service. Almost no patient is going to have that specimen arrive at the NHLS within 2 hours on ice. So it just as much as it underrepresents, it also overrepresents. So no, the long and short of it is no, ammonia is not done. You don't need to do it. If you've got a patient who is coagulopathic and has neurology, they classify as pediatric acute liver failure.
Perfect. I fully agree. Lesego was saying thank you for the great talk.
Thanks,
Um,
Seb.
Asking ongoing support you give to our children less than three.
Ongoing support you give our
Sorry,
children.
so she's
Let's.
thanking you for that. Sorry,
Oh,
that's
I
not a
think it's a
question.
little, yeah.
Sorry,
I was like,
Lesego,
what's
I'm a
wrong
bit
going
slow.
to
Um, then Mahlatse Moshabela is asking the poor
Ooh.
prognostic factors for pediatric acute liver failure, and when will you not accept a patient to the transplant center in the acute setting?
Okay, so yeah, that's a doozy. Okay, so the truth is, they're not well known, the poor prognostic factors. There's a lot of kind of investigation that's been done into it. If you meet the closest that people have managed at this point in time is King's College criteria. The only problem with that is that reflects more who needs transplant, not necessarily who is going to die. So at this point in time, we actually aren't certain or confident about what poor prognostic factors for PULF are. We do know that obviously if you're multi-organ, that you carry an additional risk. The truth is that we will not accept a patient only if they have irreversible organ damage in another organ. So in other words, they have basically they have irreversible cardiac, irreversible respiratory, irreversible renal. But a lot of that is difficult to interpret because, for example, our patients will go onto dialysis basically straight away when they arrive with us. So we'll be able to manage any renal dysfunction. So we usually accept patients with renal and hepatic dysfunction because we are able to actually manage both of those. The truth is, it's if transfer will kill them. That's really the crux of it. So if a patient is so critically ill that they will not tolerate transfer, then they will not be able to be considered for liver transplant. Because liver transplant, your patient needs to get a little bit sicker. So you need to be able to have ventilation settings go up a little bit more. You need to have the ability to go up on the inotropic support. So that is the requirements in terms of other systems to get to transplant. But saying that, we've had patients who have arrived in critical condition that have both made it to transplant and who've actually made it without transplant. So we've had patients that we've diagnosed with who have presented in acute liver failure who've actually been diagnosed as macrophage activation syndrome or HLH, hemophagocytic lymphohistiocytosis. And those patients we've treated medically and we've actually got them through their acute liver failure without transplant. So at this point in time, the answer is almost no poor prognostic factors have been identified, except for the patient that actually can't tolerate transfer. So that's, and then usually what we try to do is we try to assist you in your management. So our ICU team are phenomenal. We've got a group of three and they're all very experienced. And we try to help you get that patient stable enough to actually tolerate transfer. And then we'll try and get them to us. Yeah.
Yeah, and this highlights the need for urgent early referral, I guess, especially in acute liver failure. I
Yeah.
see Nisha has got a hand raised. Go ahead, Nisha.
Hi, Marisa. Thank you for the talk.
Hi, Nisha.
Um, I just had a few comments and questions. The one
Sure.
is just the challenges that we face. So the reality is it's quite difficult from like to work up a patient for liver transplant.
Yeah.
So one in the acute setting, you mentioned we have 24 to 48 hours, sometimes even less to get a patient to transplant. And the reality is for us to get even a psychosocial assessment in 24 hours is very difficult. So that's the one thing. Labs again is a problem. INR levels,
Yeah.
any labs are difficult. And we also, some of us work in facilities where we don't have a 24-hour lab on site. So often waiting for these workup or pre-workup criteria often compromises the patient. And by the time we can actually get the patient to a transplant center, it's often too late. So just what can we do or how can we make protocols better to try and get the
Yeah.
patient more timeous care? That was the first thing in terms of the acutes.
So, to be honest, every acute should be managed in a center with optimal medical therapy provided because, uh, I think this is some of the confusion. A pediatric acute liver failure patient, the majority actually survive without transplant. So, you should be providing every pediatric acute liver failure patient the best opportunity to recover. Not just transplant, it should be to recovery. So, those patients should be going to a center that is able to provide dialysis, that is able to do EEGs, that is able to kind of provide every possible benefit to that patient. So, they should be in a pediatric ICU. And I know that a lot of pediatric ICUs will preclude patients from accessing them because they say, well, pediatric acute liver failure carries a poor prognosis. Well, yes, if you don't give it the maximum medical support. So the truth is that the workups shouldn't be getting done at centers, like it shouldn't be staggered throughout the medical faculty. That's not what should be done. The care of a pediatric acute liver failure patient is highly specialized and it should be done at specialized centers, and centers should be provided with like the capacity. So if, for example, your hospital is going to be looking after pediatric liver failure patients, then that center needs to say, well, to do that, I need to be able to provide dialysis. I need to be able to provide inotropic support. I need to be able to provide CTs with timeous reporting. So if you can't offer those services, then ideally you should go to a place that can offer those services. And if we offer transplant in state, which we do, then those centers that are responsible for transplant should also be responsible for best medical care. And if they are not responsible for best medical care, they should be facilitating the provision of best medical care at other centers. So that is a hugely contentious, and I'm sure people are going to object, but the truth is that the management of a pediatric acute liver failure patient is actually first and foremost medical, not surgical, and we should be working towards actually getting best medical care for our pediatric. We'll save more patients that way. We'll actually save more patients by providing best medical care than we will by providing transplant for pediatric acute liver failure patients. So if we could just afford them the best in medical care, they would have the best shot.
Thank you, Marisa. The second one was just about liver transplant in the chronic patients. I think it's something I struggle with all the time. So we know it's a limited resource and we know it's quite intense, but you also mentioned how the psychosocial assessment's dynamic. So just because the patient doesn't qualify for transplant
Yes.
today, from whatever reason, it doesn't mean that they don't. But what I struggle with is we offer this or we mention it to every or most patients that we see who we potentially think may need a liver transplant. And sometimes it's difficult because you know by the time you've taken a social history that the chances of you getting this patient to transplant is very minimal given the social circumstances. Sometimes it's a 16-year-old mom, they live in a rural area, they have a pit latrine, and we continuously assess this. But would you offer, or maybe it's a question, at what point in the consult would you mention liver transplant is an option for this patient? Because I struggle. One, if you don't tell them about it, you don't give them that opportunity to try and make a plan, overcome the obstacles. But what we do find at the end, then, when we don't get to transplant and the patient's almost end stage, all they focus on is why is my child not getting a transplant or where's the transplant? So these are some of the things we face, and it feels like a very difficult situation. So do we offer it to everyone? Do we mention it? At what point do we? And yeah, just overcoming the obstacles are quite challenging in our setting. So I often struggle with this at the clinic.
So what we always say to our parents is, and I think I will accept that we come from a much better resourced environment in private, although sometimes not as well resourced as people think. But the point is, it's like when we discuss with a family, we say transplant is available, as in it can be done, and we are evaluating you to see if it can and should be done for your child. We kind of try and remove some of the responsibility from our patients. So we tell our patients, especially if it's like a social, we explain why, but we tell them exactly that they know they cannot be transplanted because of the fact that just like there's a medical reason that the patient cannot be transplanted, there are also social reasons why the patient cannot be transplanted. It's very difficult, especially, I mean, we've had well-resourced families that we've had to turn down. The one was medical conspiracists who believed that that medicine was a conspiracy and that it was a money-making endeavor and that all medication was towards being mind controlled and had genetically modified factors in it. At the end of the day, we had a family with the resources to pursue the fact that they had not been transplanted in the context of a family that could not be transplanted because of their complete absence of any trust or belief in anything that was about to be embarked upon. So I think it's there in every sector, it's there in every country. And I think the important thing is to tell families, and we tell our families, that transplant is not a it's not an expected thing for everyone. It's not a given for everyone, and it's not the right thing for everyone. So it's a lot about your engagement with both your social team and your education. But again, that's resource intensive. And I think that if we're going to kind of concentrate our patients in a place where they're going to be worked up, then we should work on expanding our social services because that serial assessment is what's so important and it's very resource intensive on the social workers. So there's another study that I actually didn't present, but it's a study on how stressful being a social worker in transplant is. It's highly stressful. It's incredibly stressful because they are having to not only see the patient once, they're seeing the patient on multiple occasions. So this is also, though, to me, a part of timing of referral because when we get patients early, we have the opportunity to better explore the social aspects and do something about them. Whereas if you get a patient late, then there's no opportunity to do anything about it. It's absolute, you know? So it's the time that they are with you that affords you the best opportunity to do something about it. But it does need the social support from the divisions to do it. And I don't know if you guys, I don't think that that's in place at the moment. So that's something that I think needs to be worked on. I think it's an absolutely essential part of your, like, the service provision. I don't think any family should not be told that transplant's available. But I don't think when our families come, we tell them that this is just about whether you can get transplanted. This is not about you getting a transplant. And we make very clear lines between the candidate and the listed. I don't think there's an easy answer to it, though. I think that there will always be that element of knowing that a patient is not going to be able to meet those criteria and knowing that there's no way to reverse it. I'm sorry, there
Thank you,
isn't an easy
Marisa.
answer.
Thank
I
you.
wish there was one because I think everyone grapples with it.
Yeah, yeah. No, thank you. Thanks for that.
Rita, I see there's a few people that have asked in the chat
Oh,
if you
yeah, I
can
see
send
that.
the link
Let me
for the
just
referral.
see. Let me just see if I can get it. Uh,
Meanwhile, if anyone else has a question, now's your chance. I don't see any
oh, yeah.
more hands. Yeah, there we go. There's your link.
There's the link.
Marisa, thank you so much. It was an excellent talk. I really enjoyed it. Yeah, we'll have you back again next year, I'm sure. Thank you.
Thanks, Tim, and thanks
Um,
for hosting.
no problem. And then just to mention, thank you to the Gastro Foundation for their support for Echo New Mexico and Echo India team who do the technical support. A big thank you to the sponsors and to all of you for attending. And of course, again, to Marisa. Next week, for those of you around, will be pancreatology. So thank you, everyone, and goodbye.
Thanks, Tim.